Thank you, Chairperson. Ladies and gentlemen, I don't have any disclosure. Everybody knows the terms of arrhythmia-induced cardiomyopathy, AIC. Strictly speaking, AIC includes tachycardia-induced cardiomyopathy or PVC-induced cardiomyopathy. Later two subjects used to be included as AIC, but recently recognized as cardiomyopathy due to conduction abnormality. However, the terms of Preexcitation-induced cardiomyopathy (PIC) is not still popular. So today I will focus on the Preexcitation-induced cardiomyopathy (PIC). Accessory pathway and cardiomyopathy are sometimes observed in the same patient, such as hypertrophic cardiomyopathy, PRKAG2 syndrome, Danon disease, neuromuscular disease, and et al. PIC also shows both findings of accessory pathway and cardiomyopathy. In these diseases, primary factor of cardiomyopathy is myocardium itself. In PIC, primary factor is accessory pathway. The preexcitation through the accessory pathway caused ventricular dyssynchrony, resulted in cardiomyopathy. It should be wise to distinguish PIC from other heading of cardiomyopathy. I will show the typical case report of PIC. This is a 5-month-old girl without any history of PSVT. 12-lead ECG showed the pre-excitation due to right anterior accessory pathway. After treatment, the pre-excitation disappeared. When the pre-excitation was observed, LV function was severely reduced of LV ejection fraction 24% and ventricular dyssynchrony. After treatment, LV ejection fraction increased to 37% with improved LV ventricular dyssynchrony. Let's enlarge the M mode before treatment. Interventricular septum moved inward within the QRS complex, and then showed dyskinesis in the mid-systole. This is another case report of a 4-month-old girl with PIC. They show the morphological change of the basal interventricular septum at 1 day of the age, showing the normal LVA structure. At 2 weeks of the age, aneurysmal formation of basal interventricular septum was observed. At 4 months of age, progressed aneurysm formation and local thinning of basal interventricular septum appeared. PIC is rare. We rarely see the patient with PIC in the real world. So today, I summarized PIC cases accumulated literature so as to clarify clinical features in this uncharted area. Reports potentially related to PIC were searched using PubMed from 1998 to February 2021. Key terms used were WPW syndrome or pre-excitation and cardiomyopathy, dyssynchrony, or heart failure. The cardiomyopathy defined as LV ejection fraction less than 55%, LV shortening fraction less than 25%, or obvious heart failure symptom. Excluded were primary cardiomyopathy, structural heart disease, and myocardial infarction. 34 articles met the search, describing 122 patients. Of 122 patients, 59 patients were excluded because of no detailed data. Remaining 63 patients in 29 literature were included for analysis. These data were collected: patient characteristics, history of SVT, location of accessory pathway, the treatment and their effectiveness, and the interval for recovery to normal LV function after effective treatment. Further data, as rigorous mechanical motion of the interventricular septum, such as early inward motion within the QRS complex or dyskinesis in the mid-systole, and the morphological degeneration at the basal interventricular septum, such as aneurysm, bulging, and local thinning, were evaluated. These are the results. The age at onset was median 4 years old. In total, 55 patients, 87% were children, including 16 infants, 25%. Only 8 patients, 13% were adults. Heart failure symptoms were noted in 2/3 of the patients, and then LV dysfunction was severe in 14%. This table shows the cases with severe LV dysfunction and/or manifested syncope and cardiac shock. 3 patients experienced cardiac arrest or syncope, and 1 required biventricular assist device. A third of the patients experienced SVT prior or subsequent to onset of PIC. Among 63 patients, a couple of accessory pathways were detected in 2. Accordingly, 65 accessory pathways were analyzed. All accessory pathways, except for one fasciculoventricular accessory pathway, were located around right atrioventricular junction. The septal side was commonest in 36–55%, followed by right anterior lateral in 14–22%. This slide shows the treatment and their effectiveness. Catheter ablation was performed in 49 patients, and all procedure was successful and effective, leading to improved LV function. The conduction of accessory pathways spontaneously terminated in 6 children, 4 under 2 years old, 1 4 years old, and 1 13 years old. Amiodarone, flecainide, and propafenone were administered in 12 patients. These agents were effective in 9 patients, and then accessory pathway became inactive. All 9 were under 2 years old. Anti-heart failure medication were given in 45 patients, such as beta blocker, ACEI, and/or diuretics. Although they reduced cardiac overload to a certain degree, anti-heart failure medication alone did not improve the LV function to the normal level. The duration of recovery to anticipated normal LV contractility were described in 49 patients. In 2/3 of the patients, LV function returned to normal within 6 months. On the other hand, 4 patients, 8%, took more than 3 years. The length did not correlate with the age at onset of PIC. This slide shows the ventricular motion and the morphological change at the interventricular septum. Among the patients with available data, early contraction of interventricular septum was seen within QRS complex in 14 out of 19 patients, 73%. The dyskinesis of interventricular septum at mid-systole was frequent findings in 38 of 42 patients, 90%. Among all 63 patients, aneurysm bulging of basal interventricular septum and local swelling was observed in 30, was reported to be 30, 51%, and 23, 37% respectively. However, some studies have shown that diffuse or global change is evident in the left and the right ventricle. This is a summary. Characteristics factors determined in PIC include much commoner in infants and children, exclusive accessory pathway on the right side of the AV junction, early contraction within the QRS complex, dyskinesis at mid-systole, aneurysm bulging, or local swelling at the basal segment of the interventricular septum. This slide shows a radial strain echocardiography of computer simulation with LBBB and real human with non-ischemic cardiomyopathy with LBBB. Focus on the anterior septal movement. We can see an early inward motion within the QRS complex, followed by an outward stretch in the mid-systole. This has been reported being a parameter of electromechanical dyssynchrony that predicts the potential for ventricular recovery following CRT. The whole ventricular mechanics was affected by a regional myocardial remodeling at the wall shortening early. Mechanical workload is reduced because the wall is stretched during the mid-systole and the region becomes thin. This process exaggerates rebound stretch at the systolic phase. In several patients with PIC, the spectral tracking echocardiography shows the identical pattern with that of electromechanical LBBB substrate. This is a hypothesis of mechanisms of PIC. In the PIC, due to early septal activation through the right accessory pathway, a subsequent rebound stretch following early shortening is believed to be the major mechanisms that induced ventricular dyssynchrony. The systolic rebound stretch can lead to an aneurysmal formation of the septum or degenerative local thinning of the area. The cardiac remodeling might go beyond the septum diffusely, and the septal aneurysm would become less obvious. Ladies and gentlemen, this is the conclusion. PIC should frequently be suspected and distinguished from primary cardiomyopathy. The early detection of the abnormal mechanical motion and the morphological degeneration at the basal interventricular septum might lead to an early diagnosis of PIC. Thank you for your attention.